bit of debate over the two-stent strategy in the last case, James, wasn't there?
There's quite a lot of hostility in the audience. In fact, quite a few people walked out.
Was it this side?
They said, "I'm done with this course after that lousy maxi stent crush."
And you let that do? You know, such a mission for you to change.
Yeah, there was literally a walkout from the maxi crush.
Maxi crush.
I don't know whether there's any evidence on this or not, but let's say, for example, that is the stent coming back. We put a balloon up to post out it to make this as big as possible, the ostium. We then crushed it this way with the balloon here. And I think then, I took this back and I do a kissing inflation at that time. A lot of people think that puts the stent back to how it was, but I don't think it does, because it has been crushed here and crushed here. When you do the inflation, I think it's pretty much the same thing as a DK double crush. Maybe not as beautifully as you might do if you do a DK crush, but it works very well. And recrossing that was no issue, and we're always going to do another kissing inflation. So that's how I do them. But it's not the accepted.
Well, tell it to people who's left. That's all I can say.
This is a complication talk, but it's not really a complication talk, and I think what has come through in the talks over the last few days is we spend a lot of time explaining why we're doing something in the hope that we prevent or avoid a complication rather than dealing with them. This shows our strategy in terms of how we treat CTOs. The vast majority of them are anterior wire escalation. We only use dissection techniques when we have to, and that is determined by the anatomy. What we do know from the registries and that what we've seen is that most complications or most life-threatening complications occur with epicardial perforation. So let's say, for example, you perforate a proximal right coronary artery. That's not a good thing, but you're in control of the vessel, and often you can sort it either with a covered stent or in fact even coiling it. If I had perforated that epicardial collateral before getting retrograde, I had no control over it at the other end, and it is filling from multiple sources. So even if I put a balloon up in that epicardial, it's continuing to bleed from multiple sources, so the patient is going to tamponade. And what this slide shows is that the deaths are predominantly in the retrograde group. So whenever people talk about, I always go retrograde, and people love doing retrograde procedures, there is a penalty associated with it. So first thing about complication management is never forget the basics. So this was the day before we were doing live cases to PCR in Bristol. This is a 5mm CTO. This is a warm-up case for a visiting operator.
Very famous visiting operator.
So what has happened? So watch it again. So this is a 3D guide. So it's a very short occlusion. The vessel is a bit small and slightly anterior. So he uses a guide cath extension delivered over a balloon, the wires in the RV branch, and then puts a diagnostic catheter in to the left side to do a contralateral injection. Okay. So it's injected down through a guide cath extension, which is completely wedged. So if you were to look at the waveform in the guide cath extension, it would not be aortic pressure. That waveform, and you completely destroy the vessel. That's okay, not a worry about it. Anterior wire escalation. So here we have what looks to be a clear cap, longish occlusion, but you know where you're going in terms of wiring. This is a Gaia third microcatheter anchor balloon. Looks good?
Yeah.
Happy with how it's going? Keep on trucking?
Do you need the Gaia for when you see a track like that?
It's what we did. I'm not showing you all the pictures, I'm just making a point.
Why not use a more polymeric that will selectively go through the microcatheter?
Okay, yep, good point. What feedback do you have from the Gaia? None. So, but does this wire look good?
Off plane.
You're outside the vessel.
And of course, those weren't microchannels, those were collateral branches. And there was uncertainty at the proximal cap. And the point is that, you know, you get absolutely no feedback from a Gaia. So this looks like this is the start, and this is the vessel going down. But these are probably bridging collaterals, or, you know, it's not the vessel. And then you take a Gaia third, which is not a good choice of wire in this situation. Angiographically, it looks very good, but of course you've got no feedback. And you switch to another view, and it's nowhere. So go retrograde to get the case done, and what do you notice?
Section.
It's not just a dissection, it's a perforation. Perforation, which has to be treated with a covered stent. So that's not very good. Having opened up a vessel and then putting on a load of covered stents. And this all came from antegrade wire escalation, but with the wrong wire in the wrong situation. Okay. Generally, if a wire exits a vessel, you get away with that. It's whenever you follow it with equipment that you don't get away with it. Now, the next case, unfortunately, was also in our hospital. Now, it wasn't me, but watch this through and point out the mistakes, okay?
That's the LED.
So how long is that occlusion?
Very short.
Okay, so this is a pallet 200.
This is you, Colm, isn't it?
This is me. This is back in the day.
It's funny wire.
Good? Yep. Sorted? Can't see. Can't see.
Most likely that wire distally is in a dissection plane.
You were lucky. Okay, you can't see what's going on, so he gives it a squeeze.
There's a lever distally.
So what's going on?
It's already there is a well, the whole thing is smashed.
Okay, so let's go through this. Right, so it's a short occlusion. This wire, subintimal,
What wire is?
pallet 200. So it's subintimal. Now, you know, as you know now, if you took a stingray in here, that's a penalty kick in terms of, but what's the chance of the wire going from a subintimal course back in to the vessel? Not very high. Watch the way the wire behaves. So equipment often behaves like this. Okay, so watch the wiring. So the wire, no, releases. So see when it pops and releases, that's somewhere very good or somewhere very bad. In this case, it's not somewhere very good. So what are the mistakes that have been made so far?
Balloons. I mean, the balloon is
Choice
without being sure.
No, we're not at the balloon yet.
Until now,
position.
until now,
Choice of the wire, yep. Choice of the operator first. Choice of the operator. Choice of the wire.
Not noticing this problem. I mean, this was quite, retrospectively, it looks quite obvious that it was not in the right plane.
How can you prove where the wire is? Pardon?
comparing this.
What type of injection? Contralateral. So up until now, he hasn't done a whole lot wrong. He's been a bit unlucky, hasn't done anything much wrong, except he now does an antegrade injection, and as often happens, collateral filling changes. So he's got no antegrade flow. Okay, so up until now, he hasn't done a lot wrong. But if he had a contralateral injection, the wire which you think is going down the LAD will not be. But up until now, he doesn't know that. Now watch where the wire is. So one of the clues is look where the wire is. Okay. Now the wire is moving towards me. He then takes a balloon because he can't see what's going on. And this is the mistake. This is the real disaster. Up until now, it's manageable. But whenever you balloon into the pericardial space, and there's a hint there, isn't it?
Yeah.
You can see some filling here. The wire has moved round 3 or 4 centimetres. It's not in the vessel. So there were clues. But he still is unsure, still can't see. And this is back to our dependence on angiographic evidence. Right? So that last case we give about 100 mils of contrast. And once we get into the business end, you saw Hussam take the syringe off the antegrade catheter so that we couldn't do an antegrade injection. If you want to see what's going on, take an IVUS. If you want to see what's going on, do a retrograde injection, but not antegrade injections. He then follows it up with a bigger balloon. Look where the wire is in this iliocranial. It's away over to 8 o'clock, so the wire had moved from here all the way over to here. So this patient had to go to emergency cardiac surgery. Thankfully they survived it, but
Amazing that they did.
amazing.
What is the correct choice with the wire?
Any number of them. What do you think? Is the cap clear or ambiguous? Clear. Is the occlusion long or short? Short. Is there a landing zone? Yes. Is there a retrograde option? You didn't see it. So it's antegrade wire escalation with antegrade dissection artery bailout and a retrograde bailout. So the Pilot 200 wasn't a bad choice of a wire, but he didn't have a microcatheter. He didn't have contralateral injections. And then when he went subintimal beyond the distal cap, what he should have done was bring in a Stingray. But he didn't know how to. Now, he might have been better actually with a CP12 and a bit more feel. Okay, so
A question about the last case. Could you think of any other way of solving the problem without sending this patient to surgery?
no, we don't send people to surgery quickly enough. For a surgeon to deal with epicardial vessel bleeding is very easy. I've had one elective death in my career, and it was an epicardial vessel perforation where we couldn't get the vessel open, and we spent too long trying to solve it. And she went to cardiac surgery, and it took the surgeon 2 seconds to fix it, but she died from liver failure because of the hypotension from the prolonged attempts to so I think it's the one situation.
What does the surgeon do? How does he treat? I mean,
Glue. Well, first of all, he can find it.
Okay.
He can see the blood. It's easy. He's got he can find it, and he just puts a patch over it, glues it. Doesn't even have to put you on bypass. Surgeons can deal with bleeding very, 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 very quickly. They take people back all the time post-op with bleeding. It's their job. It's what they're good at. So I think it's the one time that we are too slow to speak to them because we're embarrassed about, it's not you're sending them for emergency bypass. They might graft it when they're in there, but the predominant thing they're going to do is stop the bleeding. And then we get into a situation where you're giving them protamine to try and stop bleeding. You've got balloons up, it's a scheme, I think we're too slow to speak to them. Okay, so uncertainty. Where is the vessel going?
This is breaching to levels.
Yep. So I'm going to give you 2 options. Is the vessel going up and over or down and straight?
I don't know.
No, it's straight. You have 2 choices. You have to choose. Who thinks it's going up and over? You have to give me a choice.
down.
So I like the guy who says, I don't know. Because look what I did. Went up and over. What's that called? That's a perforation. So that's up and over with a CP12. It's probably a fine cross microcatheter, 8 French guide, and no idea where the vessel goes. Okay, so if you don't know where the vessel goes, you don't guess. Or what do you do? Right, imaging. What else? That's if we don't have imaging. How can we follow the course of a vessel when we're unsure? Dissection. Knuckle. Knuckling. So if you're unsure of the course, you don't go with stiff wires. You can use all the additional modalities, but you still don't do that. If you're unsure of the course, you use dissection techniques. You switch to a knuckle wire. So if you don't know where it's going, the penetration wire, as we've seen in this case, and the guy a third, these wires will exit the vessel and you'll have no clue until there's a perforation. Had we used a side base, had we used base, had we used dissection from the get-go, that would have solved this uncertainty. Okay? And if you look at any of the registries, the Japanese registries, there's more wire perforations from anterograde wire escalation or retrograde wire escalation techniques than there are from the dissection techniques. Okay, so there's a couple of things you do with anterograde dissection or entry. Up until now, the cap is arterial pressure, but the distal vessel is protected. And remember, this is filled by collateral, so this is a low pressure system. But once you penetrate that proximal cap, you're exposing that dissection plane to arterial pressure, okay? And you will get hematoma formation and compression. What we teach people to do is, once you have penetrated the proximal cap, you don't do any anterograde injections. So this doesn't project particularly well. This is myself and Simon. This is a crossboss been used to finish out the last 15 millimeters off a CTO, and this is a retrograde injection. Okay, so we'll play through that again and explain to me what has happened. Someone injected the wrong guide. And who is that person? So this is the crossboss. Watch my hands down here, bottom right. Look how fast we spin the crossboss. The crossboss comes down to the landing zone. So we want to do a retrograde injection to see the landing zone.
Simon.
Oh. Now watch what happens. I turn away.
Yes.
I go, oh, flip. Watch it again. And there's 3 things to watch. Number 1, watch my reaction. Watch what Dr. Walsh does, and this is Chris, our nurse. He's a really good nurse, so he's diligently working away, looking after the equipment. Okay, you got to remember now, Dr. Walsh is a big lad. He's a strong lad. So injecting, boom. Right. So I go, oh flip. Simon goes, it's not my fault.
And he threw
Threw away. And then Chris, the nurse, he's going, what happened? Who did that? Who did that?
Yeah, where did that come from?
Where'd that come from? Okay, and what has happened to this vessel? There's dissection. You've destroyed it. You've completely. So it's not that we're saying don't do it because we don't want you to save on, or want you to save on contrast. This vessel is destroyed. This vessel is completely destroyed. And the other thing to point to make out. Let's say, for example, we've done all this dissection, right? The contrast has highlighted it. And you're retrograde, and you've done all this dissection, and you're trying to wire from here up through all the dissection into the guide. What's the chances of you doing that? 0. So when we bring a guide cath extension down to here and put a balloon up, we're trying to shorten the distance that you have to wire through all this disruption. Okay? But
So
once you...
So you stopped? Yeah, that's it.
It's dead. It's toast.
Somebody
toast.
did that to me just before a live case in China. Do you remember that? Where I
It
scrubbed, injected, the artery looked like that, and he scrubbed and said, "There you go." Thanks. And you're live. And the screen going like this, and everybody looking at me going, "What have you done?" And I'm like,
Is there any way to solve this, apart from a time machine? You have to get retrograde into the PL, connect it all. You have to get retrograde into the PDA, connect it all, ensuring that you've connected here and here, and then you have to get into this RV branch and connect it all. It's goosed.
What about, does it heal if you leave it and come back?
You've no other choice, you have to just leave it. Now, ironically, it was such a powerful injection that it all cleared. So you'll probably come back and find that there's flow into all those branches.
Colm, I have a question actually.
Yep.
Just throwing this question. How does it heal?
I know.
I mean,
It's magic.
It's unbelievable. I mean, I don't understand how does it really, I mean, when you have this and you come back, you still have a lumen. I mean, why doesn't it recruit completely?
Well, what I think happens is you have flow which goes down partly in the lumen, then partly dissects and then back. And whenever you try to wire these on the next day, you can't. You know, those recanalized occlusions are so difficult to wire because it's like a 3D helix which is connected in different spaces. So I think it's because you've got outflow and blood flowing in different directions, it somehow managed to heal up, but I don't have a good enough explanation for you.
I mean, Colm, just a question here. With this section that has happened, and obviously this is the contrast, but you still have blood that's pumping through this.
Yeah,
I
yeah.
mean, if you had a dissection plane which is open to the blood pressure, the same thing would happen.
it's not
I mean,
open
why
to
does-
PLV though, is
What
it?
is that?
It's not open to PLV. Sometimes it pops through, sometimes it doesn't. It's very rare, you know, the whole artery will open up like magic. Usually what happens is one of the arteries open distally, the other one doesn't. So if you put in stents to PLV, you'd never see that PLV.
But what you're talking about the dissection, if it's a dissection to a dead end, that just seals up. Here we have some outflow to the RV branch in the PDA, so it's a bit like an old star. But it did very badly in the long term. You need good flow into all your distal branches if at all possible.
Will this also affect, if this was a CTO well collateralized, would this, can this jeopardize the collaterals from the left system and you get ST segment elevation on the table?
Yeah, you know, you can, but generally because it started out blocked, those collaterals which were protecting it are re-recruited, you know, so the patient was fine with this, the patient was fine, but it's just, you know, we were down here with a cross boss about to re-enter. This case was done. We had done all the hard yards, and this was just a simple. And so you mentioned this already, Hassan. So whenever we got into the business end, we took the antegrade syringe off. So you can't do it. You know, do you want to describe your color coding in the cath lab?
What I do is I standardize it in my lab. So the right, if it's right femoral, right radial, it's always for the right, and the left is for the left. The left groin for the left. The L is for left, yellow, and right, red in the red. So it's systematically we have adapted that, and then this. Oh, I know automatically if it's a red, it's a right.
What is the red band? The syringes.
The
waveform.
waveform. The other thing we do is like the case that we did with the Colm just earlier. I just disconnect the syringe.
So whenever you look at and you have a damp waveform, you go, which one is it? Which one is it? Or somebody goes to check an SCT. There's an instant. One of the cases yesterday, I was pointing out, somebody checks an SCT, and one of your less experienced colleagues will just reach to whatever guide is sitting there. You may not inject contrast, but if you inject saline, it's hydraulic dissection. So you don't want to be checking an SCT on this syringe. You know, SCT has to come from this syringe or another line, and it's having your cath lab set up to prevent disaster. So there was 2 hydraulic dissections you saw, both of which were completely preventable, both of which were done by experienced operators. And it's just simple things, but on both situations the vessel was wrecked.
What do you think? I mean, I've been around a little bit locally, and occasionally people use the assist device. I feel very nervous with it. What is your take through these procedures?
It's predominantly sold as minimising contrast, which I don't think it does. And then the other thing is, most people that I know doing coronary intervention can do that. You know, and you can certainly teach somebody to do that.
Yeah.
So why do you need it?
I actually not too hostile with it. I think it's a clear discriminator. You can adjust blood flow. It actually sometimes makes some of the single-handed stuff a little bit easier, and it makes the thing you've just seen almost impossible.
As long as it's the retrograde. So if you've got an assist,
Yeah.
it has to be on the retrograde
Yeah.
system. The retrograde system, because we feel the pressure, you know, you subconsciously, if you're injecting into a right coronary artery with a diagnostic angiogram, you start low and you feel the resistance, and then you overcome the resistance with your injection. You don't get that with an assist, it's binary.
That's right.
But I take the points. What I've seen in certain labs is an assist connected to a Y connector to fill both guides simultaneously. You know, it would amaze you what some people do. There was a lab in France where you had one pressure monitor. You could measure the antegrade guide or the retrograde guide, but not both.
But I mean, these are important stuff, because when we discuss to when you want to start your program, what do you need to have, what are the steps, what are the toolbox, what is your checklist. These are very, I think these are essential, basic stuff, but they're very important stuff as well.
So use of imaging to identify proximal cap, you'll be familiar with this IVUS at this stage, where this is a proximal right coronary artery. You see the small vessel, no atheroma. Here is the CTO coming in now, the shadow, and then you're now in a much bigger vessel. So that tells you you've gone from the branch, which is small, back into the large vessel. We've done a cine acquisition at the same time, and that tells you where your cap is. So if you're unsure, you use an IVUS. So in that case, Susanne and I just did, even before we went retrograde, we identified the proximal cap. We took a cine acquisition so that when we came retrograde, we knew where we were going looking for it, rather than just hoping our wire goes. So using imaging to identify landmarks. What is this? I'll move on from that. Oh yeah. Never spin a knuckle. So there's a difference between knuckling and spinning. Okay, so knuckle wire, you push, right? Crossboss, you spin, but you never spin a knuckle. Because if you spin a knuckle, this is what happens. So this is a feeler XT which has been knotted in essence by knuckling it and spinning it. And then it's formed a knot, and it's not coming back through your microcatheter. Now just imagine you've come to an epicardial collateral, you've got retrograde, you've been spinning this wire, you've got a big knuckle in it. You have to bring everything back. You have to bring everything across the collateral channel, and you potentially damage the collateral. This is quite useful for whenever you lose equipment. So this is a crossboss which is stalled. So you can't see the operator that's doing this, but he's also from Japan. And what we're using is a knuckle wire.
You didn't say the last one was.
Oh, sorry, I didn't say he was from Japan. Sorry, I just said he was an expert. Sorry. Sorry. So this is using the knuckle wire to overcome the resistance with the crossboss, okay? And then spinning the crossboss on, trying to get over this area of calcification. There's extreme resistance. I try and bring the XT back, but a lot of it remains. Okay? So I bring the XT back. You get a hint of it there, actually. So bring the XT back, and the XT has snapped. So, pardon? It's been knotted, yep, and it's broken. Can you see it angiographically? So I take the crossboss out, okay, so it's not helping. Crossboss out. How much wire is in there? Don't know. Any thoughts on how you might try and understand? You take everything out. But if there's 180 centimetre of filament of wire in there, it's staying in there. Anything we can do?
Difficult to see. I mean,
Yeah.
I had a case like that. I was not cross-crossing, but just a filament. But what I did is I trapped the balloon, put it in the guy there, and I pulled it out. There was a segment of it inside the artery, but the rest went out. I couldn't see.
So you're hoping that it's still inside the guide, and if it is inside the guide, that will solve it, won't it? So what happens here? The feeler comes out. Oh, sorry. So the feeler comes out. So the crossboss is stuck in calcium. So we push the feeler out, and the idea is you just push it on, not spin it, but the operator spun it as well. Okay.
Can you reverse what you did? Reverse.
Well, what then happened whenever this doesn't move on? I pulled the feeler because it was a bit stuck, and watch what happens.
It's a internal right now, right?
Yeah, but see, so it won't. It's trying to pull the feeler back, and it's stuck, and then it gives, and we've got part of the feeler. So one solution is actually to IVIS it, because you'll not be able to see the filament.
It's not a solution to the problem, it's just a
No,
confirmation.
but it helps you in terms of solving it.
Yeah.
Now, you could take the view that you just put a trap balloon up here and pull, and if it's in the guide, great, and if it's not in the guide, great. Okay. So here's the offender. I've got the IVIS column.
Are you using is an 8-French system now?
Oh, that was a few years ago. Don't do that anymore. So an 8 French. You can see that the feeler's here, and you don't know how much is left. So you do an IVIS, but you IVIS the guide, and the IVIS shows that there's a bit of wire in the guide. And in fact, was able to measure how far back in the guide the filament went. And then that meant I was not going to leave anything in here. Now, let's say, for example, it broke off here. You could just leave it off. You know, it's not, but if it's 150 centimetres, I'd like to know it. So what I did was then put a 3/0 balloon up, trap it in the guide, and pull everything out.
Did it bring that segment to it?
Watch. So get a good hold of it, send it for production,
Oh, it's coming down.
come out.
Okay, so it's that's the effect of the trap.
Okay, so that was the filament, but you can't see it.
It's very difficult to see.
Did a case in Bournemouth with Sunil where we had an externalised wire and we had an undilatable lesion. So, undilatable lesion, and decided to laser on the RG3. So externalised wire, turnpike spiral, or turnpike LP was here. So we brought the laser down. Basically, the laser monorail part got stuck in the artery, which is all heavily calcified. Okay. You can't see it, but you can measure it. So you can take a new laser and measure it, stick it against the wall, and then you take your old laser and you measure it from the gap is what is still inside the patient. So we tried to snare it, because remember we got externalised wire, but couldn't get a snare down through it, just couldn't get through it. So we took the idea, well, I've got a retrograde microcatheter on the same wire as the laser, and just snooker it back up
Into the guy.
into the gap.
And then trap and pull.
But it didn't work. And the front end of the laser is what?
But this
Very hot.
Yeah.
And what is this made of?
plastic.
Plastic. And what happens whenever you put plastic Very hot stuff.
Use it.
It got stuck.
How long can you use?
So now I've got a retrograde microcatheter stuck to the front end of the laser.
Just cut the back end of the microcatheter and pull everything out.
No.
Probably better.
No.
I couldn't do that.
This is the laser. The laser's on the wire. I can't get the laser out. And now I've got the microcatheter stuck onto the laser. And now I'm thinking,
Switch the laser on again until it melts the
the
connection.
laser's broken.
Just
Was
keep
that
melting.
The laser's
That's
broken.
broken, okay. But another laser beside it, that laser.
Laser all on
Yeah,
laser.
no,
Laser. So I pulled, and eventually this broke, and I just took everything out, and I was so delighted to get everything out, I just left the free. So even though we
What
had
did you do? You just pulled it.
pulled it,
I thought this was some genius solution.
no, but it was a process I've been cardiac collateral,
Yeah.
and I just pulled it, but
So you pull this way or this way?
back.
So when you pump the guide, there is called ostial dissection.
Yeah, you got to have your guide well up in the aorta. You've externalized wire, get your guides way back. So if we're pulling equipment, that's when you bring guides in, so you've got to be very careful.
Can we put a balloon to protect?
You don't need to, just keep it way in.
But even surgery is not an option here, is it?
No.
They can't do anything with
That's right.
surgery.
But the annoying thing was, we reconnected, all we need to do was switch to rotablation and that great system, the case was done. But trying to laser on an RG3 in a heavily calcified CTO, just because it hadn't been done before, was stupid. And then, whenever the microcatheter was stuck to the end of the laser, I wasn't happy.
No. At least you had a flight to look forward to.
So IVUS guiding, we talk about this. You have to use IVUS for imaging in these cases. You got to select, and if you've got, if you've got a subintimal passage but not a lot of calcification, the vessel behaves well. Whereas here is a subintimal with dense calcification. You have to be careful in that situation because your stent will not modify this. Your stent is going to go in that direction. You just have to be careful in that scenario. So if you're in intimal plaque and you post-dilate a stent, you will be able to predict. But if you're in the subintimal space with dense calcification down here, you're not going to modify this very much, and your stent is going to go out into the adventitia, and you have to just be very careful. This is just more imaging, so I think I'll leave it at that. This just is a case where there's an LED that you wire, and you just have no idea from the imaging, or sorry, from the angiogram. The distal vessel is small but not much atheroma. That's a subintimal segment. And then minor, I think in this case, after we stented the bit where we've got atheroma, we put a drug-eluting balloon down to the outflow to try and improve as much outflow as you can. And this sort of vessel will heal up. Okay, so 3 months, it has improved significantly. It's still a small vessel, but we avoided putting stents all the way down to the apex. We avoided putting stents into a bridge segment. Okay, any questions?
One question regarding that, do you do any card faces?
Any what, sorry?
Yeah, retrograde technique, and if then some details about how to track the balloon and what sizes to select from, and whether we upgrade and
How many retrograde cases have you done?
not.
So don't learn card.
So it should always be.
Yep.
What about you people? Are you doing card faces?
But I'm worried that if I tell you, you'll try it. So I'm not going to tell you. You can bring. You saw James bring in a 1.5 and a 2 balloon retrograde already. So in the septal, they're generally forgiving. People have brought stents down the septum and stented the vessel from below. So again, I wouldn't recommend that. If you have a really resistant lesion, sometimes coming from below, but it's the same as an antegrade approach. It's a low profile balloon and try and upsize. The worry with a monorail system retrograde is you don't have as much control of it, and you kink a shaft or whatever, it might get stuck. So just try and avoid it.